We have 2 more sessions to go, and I believe that you guys have been really enjoying the earlier section. Next we're gonna have Dr. Linda Neuhauser and then Dr. Winston Chen gonna present together, right? Their topic is participatory design of public health interventions. Dr. Linda Neuhauser is a clinical professor of community health sciences at the UC Berkeley School of Public Health. And she's also the co-PI at the Health Research for Action Center. Her research and teaching are focused on participatory approaches to improve large-scale health interventions and policies. She has an MPH and a Dr. PH in public health nutrition from UC Berkeley. Dr. Winston Chen is a research professor at School of Public Health, Division of Community Health Science at UC Berkeley as well. He is also a visiting professor at College of Public Health, National Taiwan University here. His research focuses on social and behavioral health, diabetes and other conditions, and health literacy, and he has made major contributions on health equity, participatory design, and community health. He has a BA in biology from Johns Hopkins University and a PhD in medical sociology from UC San Francisco in the United States. Let's welcome Dr. Neuhauser and Dr. Chen.
Participatory design, and we're going to be talking about how that can really help you achieve health equity and resilience. And we'll be talking about our center at the University of California, Berkeley, and we'll talk a little bit about some of the models and methods of doing participatory work. So participatory work is really hard. It's expensive. It takes a lot of time. I see people nodding over here, right? It's expensive, huh? It takes time. And sometimes our institutions don't really appreciate that work. So why should we do it? Well, some of the reasons are right here. You know, one of the things when I got into public health, I was really interested in do health interventions work? Because I focus on action, health interventions. And looking at the research, what you find is a lot of times there's very disappointing outcomes. Now that shouldn't be, right? You do a lot of hard work. Where are the outcomes? Disappointing. And we're hoping to achieve health equity, but often we find that disparities just get wider when we try to do certain interventions rather than narrower. So that's frustrating too. This was kind of a shocking statistic when I looked at it, but it's estimated that less than 1% of clinical research is ever translated into effective health interventions. And, you know, it's kind of mind-boggling. We do tons and tons of research, but what's happening? How come we can't get that research, that very important scientific evidence, into health interventions that work? So one of the findings is that when experts, those would be people like us, when we design interventions, they're often not relevant to the lives of people that we are intending to benefit and the stakeholders who work with them. So decided to do it. I'm going to give you a short story about myself. This is from years ago when I was first starting my career. So I was working with the Ministry of Health in the country of Mauritania in West Africa. This is a country, you can see it right there, and it's mostly in the Sahara Desert. So I was working with the Ministry of Health to set up a national vaccination program. Now, this country had been trying and failing to get a national vaccination program going for 20 years. And every year, over 10,000 children died from preventable diseases. So this was a serious, super serious crisis. And I went there with a real sense of purpose, like I could actually help get this problem solved. So I went to see the Minister of Health, and a plan had already been developed. And it was developed by an expert from the World Health Organization. So I read the plan, and it sounded very reasonable. It was a textbook plan of how to do a very good vaccination program. So I began to worry after that, because if they've been trying and failing for 20 years, what was going on? I went to see the minister and I said, I'm worried about this. He said, I am too. He said, experts have been coming and developing these plans for us for 20 years and they all failed. I said, well, this one failed. He said, yes. I said, why? He said, I don't know. So I said, we don't want to be the 21st failure. I don't. And so what we decided to do was just to throw away the plan and just do something intuitive. We didn't have access to all these participatory methods that we're going to talk about today, the work that you all do now. So we just went around the country for 6 months, everywhere we could. We talked to people, not just the leaders, but we talked to everyone we could find, including people who didn't really have a voice, but really needed vaccinations. And what we found was a whole range of political, economic, religious, social, and cultural issues that an expert from another country would not have known about. And when we went to talk to people about these issues, we also asked them, what would you do to solve it? And so they began to list out all these ideas. Here's what we could do about this. Here's what we could do about that. So we ended up with a whole list of problems and a whole list of solutions to those problems, and we had one left. And that was, how do you keep the vaccines cold in the Sahara Desert? So we thought we couldn't solve that, and maybe we would fail again. But we decided to keep on with our work of doing participatory discussions, and we found a solution. See these guys? These are camel herders. So we went to them one day, and we were talking to them, and they said, oh, we know how to do that. We have a series of small electrochemical refrigerators in the desert, and we use those to vaccinate the camels. So we said, would you consider putting vaccine for children? They said, oh, sure. 20 years of failures, and these guys had the answer, but no one asked them. So, long story short, we began to build our own plan with the help of the people, and within 2 years we had 85% success rate, one of the highest vaccination rates in the world. So that was my big aha moment, and I thought, for the rest of my career, I'm going to look into how to do participatory work, really learn more about it, and then make that my contribution. So Winston, what about you? Why did you decide to do this crazy work?
Well, I think, I'm going to say crazy, but I think I was so curious, as I got my PhD in medical sociology and a postdoc now at behavioral factors at UC Berkeley, NIH Grant postdoc. And I was very interested in continuing to work with Chinatown community. So I went to San Francisco Chinatown, and 2 elders invited me to a really nice dim sum restaurant. I'm so excited, I want to help Chinatown. What can I do? And then the elders, delicious dim sum. And then at the end of the dim sum, they asked me, Winston, so do you live in Chinatown? I said, no. Okay, so I live in Moraga, the East Bay. And then they said, what would you consider moving to Chinatown? You know, we need someone like you to, contribute. I said, no, this is my family house in the East Bay. So they didn't talk to me again for almost 10 years. But, so, who am I? This is postdoc. So, but gratefully they came back, and 10 years later, something came up. AT&T was supposed to build some macro tower phages to expand kind of reception, and it was at a neighbor's house. They were also part of the neighborhood association in Chinatown. So they came for help, and we did some door-to-door surveys. I'm grateful they remembered me, because I was still doing work, from after my PhD till when they called me again on various committees. But I think it was a good lesson for me, I can't do this without my community partners.
Thank you, Winston. So, let's talk a little bit about the center. Winston and I both work at the center called Health Research for
Action
at UC Berkeley. And just an interesting piece of information. I'm not sure any of you know this yet, but the founder of our center is Leonard Syme, who's the founder of the Social Determinants of Health. So we had a really solid foundation there. We had a lot of pressure on us to do well and focus on that. And our mission is really simply health equity and success. And our team is interesting because we have a mix of researchers and clinicians. Those include like medical people as well as community practitioners. And we have people very proficient in communication and health literacy, and also with policy skills. So we mix all these people together and work like that from different disciplines and perspectives. That's not our secret sauce, though. The real special thing that we do is participatory design, real intensive participatory design. So we co-design, co-implement, and we co-evaluate with the people we are intending to serve and the stakeholders who serve them. Here's our website in case you want to go on sometime. There's a beautiful picture of Berkeley looking at the Golden Gate Bridge there. We have had a really nice partnership here with National Taiwan University. Winston, why don't you say more about that?
Yeah. I know back in 2015, we were trying to organize a labor conference at UC Berkeley with the Institute for East Asian Studies as a co-sponsor. And at the time, we were looking for labor experts at NTU. We invited Chen from the Institute for Policy Management and others, and also some faculty from China. And we really kind of very excited. And Chen said, would you like to, we'd like to invite Susan Chen to also come. So I said, okay, welcome. So that's how we got started. It was also part of the Taiwan 顶尖大学政策联盟. One of the initiatives back then by the Taiwan government to support these exchanges, research educational exchanges with the U.S. At the time, I think it was with 12 U.S. universities, some of that initiative back then. So grateful for that opportunity. And since then, being able to, Professor Susan Chen invited me to come back the next summer to do a class in the summer in a remote rural region in Taiwan to do a research class there, a class with a kind of a field trips. I remember 2 field trips to this site in Yunlin, Myeongqing. So it was a very good experience, and certainly more recently with Professor Tuan Chen, also with community engagement classes going to Beito, and for that one Juan. So very good connections. Grateful for those opportunities and continuing connections. And part of this work, certainly Len Stein was the father of social epidemiology, but certainly there's a sociologist, Irving Kenneth Zola, really coined this upstream, downstream. So back in the 60s, and he was a sociologist who focused on disabilities. He also had some challenges himself, and he wrote about that. And it's been coined and used in public health ever since. So, people are falling, drowning. So, people, you could just try to save them when they're drowning, but should we be looking upstream to see why they're falling into the river in the first place? So, this has been a well-known in the public health field for sure for a long time. And certainly, as it evolved, there's a more extensive socio-ecological framework together with the medical model that's been expanded. And this one is developed by the Alameda County Public Health Department, which is our local region public health department, really thinking about the issues, from mortality individually, infant mortality, life expectancy, to chronic conditions, infectious diseases. So more kind of the downstream health status, but also looking at health behavior, individual risk factors, exposures, and certainly protective factors, and then looking upstream, social community issues, as well as institutional and policy issues upstream. So certainly at every level, we need critical people to work together, All the levels are important, whether it's downstream or upstream. So it's really a partnership. And thinking about participatory design and models, there's really two approaches. One is from social sciences, and one is from engineering. And from the social sciences, the traditional approach is really the Lewin model, called action research. Really thinking about, is there something we could do, to make in the community, to make it useful or helpful, to improve something in the community, problem solving. And oftentimes it was not an approach that was everybody had a chance to participate in. And then the Southern tradition evolved, the 50s, 60s, Paulo Freire, Latin America, and certainly other regions started to think about, more critically, even challenged or vulnerable or disadvantaged communities can have an opportunity to they also have assets, within the community and really can build up. And there could be a more participatory and emancipatory approach. So two basic approaches. And certainly with Paulo Freire's praxis or conscientiation, it's really, starting to think about how communities can kind of take initiative and with people from the outside also be allies, but also partners with expertise to work together. And I think that critical, is really in this work, all of us here may have some skills, and we can contribute to some communities, maybe some of our own communities or other communities. But it's really important to have the faith in the people, as he says, to believe in the possibility that they can create and change things, kind of believe. And education is liberation. It's really helping people understand what can work, and they also tell us what works in the community together. And co-learning, and certainly to the extent that they are more conscientized, they insert themselves. So communities, insert into subjects into their own history, really kind of taking ownership, taking control. And I'll talk a little bit about one of my projects. In this case, California Arsenic Reduction Project. We partner with Allensworth, which is in San Joaquin Valley, California. It's kind of in a desert. And it's the first African-American town in California, established by Colonel Allensworth in 1908. And when it started, that was around the time when Tulare Lake was drained and dry. So there's some land somewhere around the Tulare Basin. The state gave Colonel Hollingsworth this piece of land. Very bad land, actually. And it had very terrible arsenic level, which was over 300 parts per billion. To be safe drinking water for groundwater, you have to be under 10 parts per billion. So it's very serious. And today, the groundwater is still at that same level, very high levels of arsenic concentration. So they had an issue, and they found us at UC Berkeley. We had some really good engineers who was actually doing really good arsenic remediation technology using electrical chemical arsenic reduction. And it was very successful. Some of the work with Professor Ashok Gadgil was in India, in the Philippines, and other places. And there was a critique of Ashok at the time, you should do it in your backyard, California. So that's when he started to also take initiative here in California. And Allensworth, back in 2017, was one of those towns where he started to. And then I joined Ashok in 2018 to partner with Allensworth. And also, we did some key foreign interviews or community interviews to try to understand what are some issues. It's whether they really want us to be there. If this is something they need. So, some of the community perceptions about, many of the community leaders felt, this is something, there is a high risk, it hasn't been successful. And certainly for Latin workers, on the other hand, it's mostly now a Latin farm worker community now than the original African American community. And many of them are not aware of these issues. So they suggested, these Spanish-speaking communities are very hard to reach, so finding a way maybe through their kids, their children. So maybe through the elementary school, there's a way we can do that. So that's how we created also some STEM education classes, teaching about water safety, air quality, various issues moving forward. And, so it's a win-win. We wanted to support. We also could do the experiments and field testing for the arsenic remediation technology. At the same time, they wanted something back, and we went to with my Cal students. Usually once a month, we take 3 or 4 Cal students, and they go teach. And I get to be the driver, driving down 4 plus hours, driving back 4 plus hours. Incredible day, on the trip. So I'll pass it to you, Linda.
I think we may be more familiar with the emergence of participatory design from the social sciences. But there's another equal track that happened around the same time, and that happened from the engineering and socio-technical sciences. Those are things like, besides engineering, computer science, architecture, informatics, that kind of thing. And so this engineering, I'll just call it engineering for short, this group of disciplines, they really started using something called user-centered design. And this was beginning around the 1970s. And since it was used in engineering, it is now during this century that user-centered design has moved from engineering over to the social sciences, policy, education, and really all disciplines. So why did this start? Well, there are 2 engineers by the name of Rittel and Weber. And in 1973, they were concerned about something, and that was, why are some engineering problems so hard to solve? Just like I was saying, I was so concerned about why health interventions are so difficult to solve. And what they said was, we really need to understand more about the nature of problems. So they created these criteria that are called complex problems factors. And you can see, this is just 7, but you could figure there might be 100 of these. And I think it's really instructive just to look through these and think about, do we really think deeply about the nature of the problems we're trying to solve? And I like to look at this and think about COVID-19. And I think if you look at this list of criteria, every single one of those would be a factor in COVID-19 and its difficulty to be solved. So we often use this in teaching at Berkeley because it's very effective to help people think a little more deeply about what is a problem, a complex problem. Engineers love to use feedback loops. So they like to design something, test it, keep going through that, evaluate it until they get something that meets their needs. And there are a lot of techniques that engineers use in user-centered design, but I'm just going to talk about one here that I think is really powerful and very effective, especially in community research, and that is design thinking. And that started with the Stanford engineer on the left, David Kelly. And he came up with this technique. He founded the Stanford D School. Now there's D schools all around, including right here at NTU. He's famous in part for that, and also working with Steve Jobs to use design thinking to create the Apple products and the most successful company in the history of the world. There are 5 steps to this. The first step is to really get really deep into an issue with the people affected by it, empathize. You can use a lot of techniques to do that. You can go next to the step of defining, that's using all the scientific information you have, surveys, this and that, and get an idea of what the problem is. The next step is kind of fun. We did this in a class yesterday. And we worked with students to do a design thinking challenge on how to engage older adults in getting them connected to activities. So these can take, you can do it. We did a 15-minute exercise yesterday, and we got a lot of fantastic ideas from that. And then you go from there to prototyping and testing. Design thinking is a very participatory, very democratic type of approach. And you can bring together maybe 20 people from the community. I was thinking, Professor Chen, that would work very well with your community resilience model. Well, we'll hear about that next. And you can get rapid identification of problems and solutions. So we like to use that in a lot of the projects we have. And I will just mention one here in closing. Here's an example of one of them that we are doing with wildfire smoke exposure. And then we've been working for years in China to help support factory workers. These are migrant workers from the rural areas who come in to work in the economic zones. And they had a lot of health problems. The government was completely frustrated trying to deal with improving the health of the migrant factory workers. Asked us from Berkeley to come in and use the participatory model. So we set up design thinking exercises with them and other things, and they identified maybe hundreds of issues and many, many solutions. They came up with fantastic solutions. You can see these are the factory workers here on the left. They're meeting to come up with solutions to wellness problems that they experience in their life, not just health care, but all kinds of things. One of the things they did was to create this guide, which is a guide to life in the city that they were living in. Very easy to read, very health literate, and written by them with the help of some experts. So this is just an example of how you can use participatory techniques to take a problem that has been very frustrating, in this case to the Chinese government, turn this around into success in a fairly short period of time. So in closing, we just say that we're so happy to be here. We have benefited so greatly in our work from learning about and trying participatory design. Any last words, Winston?
Thank you.
Thank you all.
Next, I'd like to invite Dr. Chen Zhang Chen 教授. Dr. Zhang is a professor and the director of Institute of Health Behaviors and Community Science at National Taiwan University. He's also a psychiatrist. His research interests are social epidemiology, suicide prevention, and mental health interventions. He has an MD from National Taiwan University and a PhD in social and community medicine from University of Bristol.
Thank you for your very kind introduction. And so I will start with some photos and to support Linda and Winston's stories. So those activity, workshop, visit did exist, did happen. Okay, so back in 2015, myself and Professor Chen Yawen was invited to attend this wonderful conference with Linda and Winston. And so that's where we built this connection. So we have been going on for almost 10 years. Okay. And so in the following year, we invited Winston to teach with me in this health promotion in remote communities. So we bring the students to visit the town in Middle Taiwan around this major petrochemical industry park, and which is cause concern about pollution. And we talk to a variety of different organizations in the community, the health centers, NGOs, and advocates. And so it's very interesting. We visit the sites around this park. We were also visiting the factory and the park themselves. Okay, so it's really fascinating experiences. We were really grateful to be able to invite Winston and to teach in that course. And over the years, Winston came to our college to have summer intensive courses, and the most recent one is the one. So Winston taught this course with Professor Chen, another introduction to community engagement in research course. So we're really grateful that we are able to introduce and to also share the knowledge around community engagement, participatory approach, and to include that component in our curriculum at this College of Public Health. So this is just a very quick summary of my learning from these fantastic presentations. So compared to the traditional health intervention, which tend to be designed by experts using a top-button approach with mostly disappointing outcomes and also poor translation from this research finding to the communities. In comparison, the Health Research for Action Center at UC Berkeley, they have really take on this participatory design, engage the community, co-design, co-implement, and co-evaluate their interventions, and also informed by this design thinking approach. So I'm not going to share a lot of literature or research materials. I just share one institute, one project, and one research project, and one recent study we have conducted in relation to this wonderful talk. Just try to show you that we are in keeping with your aspirations in this area. So, Institute of Health Behavior and Community Sciences, that's where I'm based, is one of the 6 graduate institutes in this College of Public Health. It was founded back in 10 years ago, we are celebrating the 10 years anniversary, and as you can see, our mission is to cultivate professional talent with perspective in social ecology and multi-level systems, the ability to change individual and collective behaviors, to promote health, the capacity to conduct community interventions, and assess their effect and skills in translation and communication. So we have this wonderful faculty members and who have expertise in behavioral science and anthropology and communication and community medicine, and with the aim to use social science methodologies to study public health and to contribute to the community. And those are our research focuses with a wide range of interests across different stages of life. And this recent important projects led by our Dean, Professor Chen, and so is with the grant from the Ministry of Education, we are able to establish this population health research center with 4 different projects that involve many faculty members within the college, including Professor Chen. Okay, so she's also here, and I'm helping with the first project, and so which maybe I just skip one. So these first projects with the theme of health equity and resilience. So that's why we have this symposium in this afternoon. So within this sub projects, we have this model, this framework, and we focus on these socio-economic and political contexts to address public health challenges such as COVID-19. And we have 3 branches and involve different faculty members within the Institute of Health Policy and Management, and as well as Institute of Health Behavior and Community Sciences. And the first theme is around health system and how this health system respond to the public health emergencies such as COVID-19. And the second theme is around the impact in vulnerable groups. So for example, Claire is also with this group. And myself, with our colleague and the Institute of Health Behavior and Community Sciences, we are working on the resilience at the community level and the individual level. So Professor Chen will going to share her research findings in the next section. And finally, I'm going to share one recent project. We have applied this co-design principle and to develop a digital intervention to reduce repeated self-harm behaviors. So we are a team led by Professor Huang. Now she is based in Chen University in Tainan, and she used to work as a postdoc with our team and to develop this new intervention applying this co-design. So this is our very first experience using this co-design idea. So really fascinating journey. So in terms of digital brief contact intervention for self-harm or suicide prevention, the idea is that suicide or self-harm is very complex, also very important public health issue. There are multiple factors contributing to this behavior. And people who have self-harm before, they are at increased risk of repetition and also suicide. So there's a need for brief interventions in contrast to time-consuming, very costly, for example, individual psychotherapies. There's a need to have some intervention available at time of distress for people that can help themselves, okay, at time of distress. So we are developing this digital intervention, and we work with people with lived experiences with the aim to develop new brief contact intervention. So we have 3 service users who are very young people who have previous experience of self-harm, and we have 2 service providers who have background in psychology. They provide services, support to people on a daily basis, and also our research team. So it's a journey spanning over 1 year. So before this actual co-design process, we really carefully to prepare our service users because they could experience distress, crisis during the process. So we work with them to develop some safety planning. And over the process, we also very carefully assess any risk occurring during the process. But they have made significant contributions to the development of this invention. Okay, so this is very interesting outcome from this co-design process because at the beginning we have very little idea what would be the most appropriate, scalable, readily accessible approach for people who have experience with self-harm. So in the end, it's become very obvious that this instant messaging software applications, mobile phone, smartphone applications appear to be the ideal platforms. So it works like WhatsApp, but it's most popular in Japan, Korea, and Taiwan. So it has penetration of almost more than 90%. So all the people, I think I would say all the local people from local use this app in this it can work on a one-to-one basis and also one-to-group. So you have multiple compared to WhatsApp. You have more functions. For example, we can create an account and to work multiple users and to provide information and also to provide feedback. So we create these 6 basic functions: safety planning, some self-help skills, mood monitoring tool, and also suicide-related information, and available sources, resources or services, and the hotline numbers. So just one button can forward people to the necessary information or services. So I just use this first button, first function as an example. So when the user, they click this button, they have this option and to know more about safety planning, and then they can given a very clear, very graphic pamphlet to show to explain this invention, and they can click this link up to the safety planning website and to create their safety planning, and which can provide immediate some self-help skills at time of distress. So this is the very interesting product or outcome from this co-design. And we are in the process of doing a pilot randomized control trial. So we are expecting to finish data collection maybe by next February. So we are very excited about this result, and hopefully it can become a large-scale invention. So this is just a recap of our learning and our experience sharing. So with those approach, and we can utilize and leverage and to really develop some scalable and effective and sustainable and interventions in the community that actually can make a difference. Thank you.
Thank you, Dr. Chen. I think I'd like to open to maybe one question from the audience. I know we're running out of time, but I think this is a great opportunity. So, any questions from the audience? Yes.
Yeah, I'm just wondering if in designing the intervention with line that you came up with, did you source that from the patients that you were interested in? Did you confer with them to come up with that idea that would be the best way for them to respond to that? And how did you do that?
Yes, we very interested in research that we kind of follow this design thinking process, but at that time we are actually not aware we are doing this. But as shared by Linda, we first emphasize with the service user, identify their need, and then we develop this idea, and then we develop this prototype. So we create some raw prototype to get their feedback, and sometimes they come out very important comments, and we modify. So during this several rounds of process, and that's the end result. So their involvement and their contribution is essential in the process.
Yeah, that was my question to you, because I saw all those, I think, iterations, and it reminded me of a project that we did on mobile health with people who have Crohn's disease, and they were co-partners, and we went through a year of asking for their input. They kept changing it, and they said, no, add this feature, add this, we want something over here, we want this, and so they got to the point where they had something they liked. So I was very impressed when I saw all the iterations that you went through. And I just think it's a great project.
Thank you, and we learned a lot.